Good morning, my friends. Welcome to Alpha Physiopelvic Care. This is my channel where we talk about everything and anything pelvic floor, pelvic health, and anything related. My name is Anastasia Ovarova. I'm a pelvic floor physiotherapist. I'm qualified and practicing specialist, and I work in sunny Cyprus. And today is a lovely sunny day, and we're going to talk about very interesting and important topic for pregnant people and moms to be. Today I would like to raise the topic of episiotomy and talk about more specifically episiotomy versus natural tear during vaginal birth. This is a big discussion sometimes amongst the moms. It can be a discussion amongst the healthcare professionals. What is better? Shall we let you tear naturally, or shall we kind of take control over the situation and do the episiotomy? Let me first tell you what is episiotomy, what is natural tear, and briefly introduce you to the degree of tear. The agenda of this video is not to go into details, we can do it in another video, but to give you an understanding what is what are the risks, and what are the benefits. So first of all, vast majority of the moms, every second mom, if they are first-time mothers who are having vaginal birth, will have certain degree of a vaginal tear. And this is common and this is fairly natural as the pelvic floor and tissues around vulva, around the vaginal exit adjust as the baby exits. So the tear generally are graded to 4 degrees, and each of the degree, not the each, but the third and the fourth degree has a sub-degrees. So the tear might include just the superficial tissues, just at the entry of the vagina. It can include the superficial tissues and slightly the muscles around, the superficial muscles that surround the vaginal exit. The tear can go a bit more severe and it can go into perineal body, but do not affect the anal sphincter. And they usually are not only outside but also inside the muscle. And the tears can become quite severe. We're talking about 3rd degree C classification, 4th degree tear, where the anal sphincter is affected to certain degrees, to external part, or is torn completely. These are quite severe tears that require full-on surgical repair. Those tears are less common and usually are associated with certain birth trauma or certain complications. So it's either a long pushing stage, or there has been an emergency situation, or a baby was not in a very good position, or instruments were used, and so on. And we'll talk about instruments a little bit more when we come to episiotomy. So what is episiotomy? Surprisingly enough, when I mention this to my clients, especially pregnant clients, as they prepare, and I tell them, have you discussed episiotomy with your doctor? You know, what is the stance of the clinic, of the certain doctor? What is the protocol? They say, no, we just do as the things progress, which can indeed happen. You can't plan anything with birth, but I believe you should be informed about what episiotomy is, because in some degree it can be a choice depending on what your provider protocol is. So episiotomy is a surgical cut. I have here my lovely scissors. A surgical cut that is performed on the side of the vaginal exit, okay, and it's done as the baby is crowning. So nobody is cutting you as baby is still high up. The baby is crowning. The tissues are stretched to the max, and this is where the doctor can see where the episiotomy can be performed. Now, let me give you a general consensus on episiotomy worldwide. So, World Health Organization does not recommend episiotomy as a routine. So, episiotomy should not be a routine procedure. Unfortunately, in my practice, I do hear a lot that women are just cut because they're first-time mothers, just because they are giving birth for the first time. There is no particular reason, the baby is fine, but they are being cut. Also, the world episiotomy rate varies a lot. It's about 15 to 20% in Scandinavian countries, It can go up to 37% in the countries that are more south, such as Spain and Portugal. We here live in Cyprus. We don't have official statistics for episiotomy, but the episiotomy rate from my clinical practice is high, okay? So World Health Organization recommends that episiotomy rate in general should be around 10%. So to preserve that episiotomy for truly emergency situation, because research that has been done over these years does not support episiotomy versus natural tear. There is no better outcome for the mothers. We're talking now about majority, okay? Of course, on each individual cases will be different, but as a research, yes, as we take those thousands of people that have been participating and different outcome measures have been taken, research does not support routine episiotomy. Research only gives space to episiotomy that is medically justified. So what is medically justified episiotomy? The reason why you would need episiotomy indeed is if you have been in a pushing stage for a long time, 1 hour plus, and there is evidence for a distress to you as a birthing person or to your baby. Oxygen drop, all the vital signs are dropping. Yes, episiotomy is justified. It will increase the exit, the vaginal opening. Baby will exit faster. Episiotomy is justified if the delivery is happening with instrumentals. If the delivery is happening with vacuum, so it's a thing that sticks to the baby's head and baby is assisted to come out, again, if the pushing stage is prolonged, and to avoid ultimately emergency C-section when baby is so low, or the forceps is used, is like kind of metallic device. One part is inserted under the baby's head and the other one on top, and the babies pull out. Again, there is a high chance that the area around vagina might be injured. Again, it's preferred to create a controlled injury by cutting episiotomy. If baby is large, 4+ kilos, again, depending how is the whole birth progressing, large baby is not an indicator to episiotomy by itself, and to avoid emergency C-section. So episiotomy has its time and place. But if the mother is doing fine, if she just needs a little bit more time, position changes, and so on, then episiotomy is not justified. Or just because, she's first-time mother, let's cut her to make sure everything is fine. The difference in the anatomy, how episiotomy is performed, the recommendation, official recommendation is mediolateral. What does it mean? Episiotomy needs to be cut to the side, about 60 degrees, 45 degrees. So it's not at the opening of the vagina down, because there is a high risk of injury of perineal body. In a kind of old school episiotomies where the cuts were made down, that would injure perineal body and extend the tear, possibly. Now it's recommended to do on the side. First of all, only the muscles are, let's say, injured. And also there is a lot of good blood flow going on here, so when the episiotomy is stitched, it heals usually quite well. So there is no need to be afraid. If you really need it, discuss it with your doctor. But it's also no need to be scared of natural tear. Now, if there is evidence that you might be tearing up towards your urethra, so these things are happening during the labor. They cannot be predicted. The doctor cannot say, you will tear up to your urethra, let's do episiotomy. No. If you're tearing up to your urethra, the evidence of that, if the doctor sees that you're tearing down and the tear is extended, so these decisions are made now and then. Otherwise, it's okay to let you tear naturally. Most women will sustain first or second degree tear. First degree tears are often not even stitched, or sometimes one stitch is applied. Second degree tears, few stitches, and it heals naturally. There is no injury to your soft tissues. So the takeaway point, guys, for today is, number one, check with your doctor, talk about it, do not assume, talk about their policy and their even habits. What do they think about it? Do they follow the official guidelines of not cutting if there is no serious medical indication? Number two, do not be afraid of natural tears. They will happen. And if it's first, second, even third degree tears, all the tears, they heal well. And the big degree tears, they're quite rare as well. And again, during the labor, the decision can be made. And if you have episiotomy, we can talk about it later. Let me know in the comments if you're interested in talking about how to heal after you already had episiotomy and how to prepare and reduce your chances of not having episiotomy. Drop me in the comments what you think about it. Have you been discussing these things with your doctor? Talk about your experience. Maybe you already experienced the episiotomy and this is something you don't want to experience again. Make sure you like this video if you find it useful. Don't forget to subscribe. I will be talking more things pelvic health. I hope you have a lovely day and we'll see you very, very soon.